So I want to get into competitive bidding. As you may know, that I've been working across the aisle with a member of the Oregon delegation from the Senate on a premium support plan that uses competitive bidding to help determine the contribution. Competitive bidding we've seen has worked well in Part D and Medicare Advantage. I'd like to get your thoughts on choice and competition as it relates to these previous successful reform plans. Given what we've seen in these aspects of Medicare, do you believe that competitive bidding is a process that can be successfully applied Medicare-wide?
Yes, I think it can. Obviously, it would represent a large change from the status quo, but I think it could work. We've seen signs of this. You mentioned the Part D prescription drug program, for example, where the different drug plans compete against each other on the quality of their benefit package and the premium level. And we've seen every year since Part D started migration of beneficiaries to more efficient plans with lower premiums. So that can help. We've also seen for durable medical equipment, when we had the demonstration, that competitive bidding in this particular area of fee-for-service Medicare reduced prices that we had to pay by 40%.
By 40%?
40%, that's right.
Those are the kinds of cost savings we're going to have to achieve if we want to continue to make good on the promise of the Medicare guarantee. This is what I'm trying to get at, which is this should not be a partisan issue. Competitive bidding is something that Alice Rivlin's been a champion of, Ron Wyden's been talking about, the Bipartisan Policy Center. There's a lot of data out there that competitive bidding, when applied Medicare-wide, can achieve the benefit of keeping these benefits going while attacking root cause of cost growth. What I'm trying to get at is, we have had CBO in here that says they can't analyze it. They don't have the tools in the toolbox, I think is the word they use, to quantify competitive bidding. Do you feel more comfortable now that we've had, about a decade's worth of history on how competitive bidding has worked in aspects of Medicare, like you just suggested, that if applied throughout the Medicare system could reduce or could actually replicate those kinds of cost growth improvements?
We've done a lot of work over the years estimating the financial effects of premium support proposals and other proposals. A good place to start is the current Medicare Advantage program, because we have data for every single plan in the country on what their costs are for the standard Medicare benefit package, and we can compare that to, say, corresponding fee-for-service costs in the area. So we have a pretty good idea of the cost levels, and if the premiums reflect that difference in cost, then it's not hard to model, with some uncertainty obviously, but it's not hard to model how people would make decisions to go with this package or stay in fee-for-service or do something else. In some cases, fee-for-service would be the least expensive plan in parts of the country. So we can estimate those. We have done it, and there is potential for savings there.
That's helpful to know, because we don't see this as a big stretch, and we're applying finite dollars because of pending bankruptcy. We believe that those dollars ought to go to the people who need it the most, the poor, the sick, middle-income individuals, and less toward higher-income individuals. And if applying this, you can preserve the Medicare guarantee while also expanding patient choice and competition to try and get at excess cost growth. And it's encouraging that this data exists. I just would simply say that we need to improve our ability to get this kind of analysis going, because we don't have it here in Congress. We don't have it at CBO. And it would be fantastic to see if your office could work with CBO so that they, too, could glean the kind of analysis that you're providing.
We provide a lot of technical assistance to them, and they provide some to us. We'd be happy to work with them.